presentable and angled out. It's a little odd position. You can just introduce and then mute it.
She already did. I think that's I'm just gonna have her.
Here we go. Hello, can everybody hear me? All right, so good evening and welcome to this brief presentation on gastroesophageal reflux disease. My name is Bharat Misra and I'm a gastroenterologist with the Borden Gruber Clinic. I've been here in Jacksonville for more than 2 decades. I have a deep interest in clinical research and I'm in charge of the research division at Borden Gruber Clinic. So today we're going to spend about 20-25 minutes talking about gastroesophageal reflux disease. I'm going to run through a fair amount of information, and then at the end, I will give you a chance to ask any questions. All right, so the first thing we need to ask is, why do people have acid reflux? And unlike what most people think, the problem is not with acid. The problem is with the sphincter that protects the esophagus from all the acid in the stomach. This sphincter is a very complex sphincter made up of smooth muscles and the diaphragm. And the problem in reflux is that it just relaxes inappropriately, allowing acid to go from the stomach into the acid and thus creating gastroesophageal reflux disease. Other than surgery, there is no effective way as of yet to restore the sphincter. So all the treatment for acid reflux is focused on suppressing acid. But I just wanted to make this point up front. The problem is not the total amount of acid in the stomach. The problem is acid in the wrong place. So first thing is, even normal people have acid reflux. There are some elegant studies done about 2 decades ago in RB recruits, and they put a probe down the esophagus and measured the acid for a couple of days. So it turns out even normal people have acid reflux. This is typically after eating, is very short-lived, and typically does not cause significant amount of symptoms. On the other hand, abnormal reflux is typically at night. It's very prolonged, it causes a lot of symptoms, and sometimes it damages the lining of the esophagus. The medical name for acid in the esophagus is gastroesophageal reflux disease, and there are 2 types, erosive and non-erosive. Erosive is when there is damage to the lining of the esophagus, and non-erosive is when there is no damage to the lining of the esophagus. Non-erosive reflux disease, or what we call NERD, is much more common and much harder to treat than erosive esophagitis. Some studies show that about 10 to 20% of all the people living in the West have acid reflux, and it seems to be increasing in incidence. This may make it the most common gastrointestinal. In fact, it may make it the most common disease in the West. The main symptoms of reflux are heartburn and regurgitation. So most of my patients describe heartburn as a burning discomfort in the back of their chest. Regurgitation, on the other hand, is described as bile or acid coming into the back of the throat, typically at night. Other symptoms are trouble swallowing, severe chest pain, a lot of saliva, a constant sensation of something stuck in the throat, and nausea. Reflux symptoms can occur outside the esophagus, and many patients present with chronic cough, hoarseness of their voice, wheezing, and aspiration into the lungs, and even damage to the back of the teeth. Symptoms are considered significant if they happen more than 2 times a week. This is somewhat arbitrary, but this is how we use to decide if this is a mild or a significant amount of reflux. Reflux is not necessarily a benign condition. It can lead to many complications. It can damage the lining of the esophagus, which is called erosive esophagitis. It can lead to a narrowing of the esophagus, which is called a stricture. It can lead to a precancerous change in the lining of the esophagus, called Barrett's esophagus. And the incidence of Barrett's esophagus is increasing rapidly, as is the incidence of cancer of the esophagus. And they're both related to the rising incidence of acid reflux in the West. Reflux can also cause damage to the voice box and chronic laryngitis. It can lead to worsening of asthma, and sometimes it can damage the lungs, leading to pneumonia and narrowing of the upper airway. This is a graphic picture of how patients can progress from mild reflux to change in the lining to more advanced changes to cancer of the esophagus. In fact, reflux is considered the main mechanism for precancerous and cancerous change in the lining of the esophagus. So how do we diagnose GERD? Typically, it's based on symptoms. Patients come to you and say they have heartburn or regurgitation. You treat them with appropriate medications and they get better. That's how you make a diagnosis. Barium X-rays were used several decades ago, but are rarely used currently. And upper endoscopy, this is a test where we bring you over to a special unit. We start an IV, we put you to sleep, and we take a very flexible, very advanced camera and look at the entire esophagus, stomach, and duodenum. That test is called an upper endoscopy. Typically, we recommend an upper endoscopy for patients who have what we call danger symptoms. If they have any evidence of bleeding, anemia, they've lost weight, they have trouble swallowing, or if they have a family history of esophagus cancer. In addition, some people are considered at very high risk for the precancerous change that I had mentioned called Barrett's esophagus. These are people who are above the age of 50, typically Caucasian men, those who have obesity, smokers, and those who have a family history of cancer. So these are considered high-risk patients, and typically we recommend an upper endoscopy. A single upper endoscopy can rule out precancerous change for a lifetime. This is very useful information. So if you had an upper endoscopy at age 30, and you come to see me when you're 40, and that was a normal endoscopy, typically there is no need to repeat it. During an upper endoscopy, we can take biopsies for other diseases. If you have a narrowing, we can stretch it, and then we can stage the inflammation. And there are 2 major classifications, and they go from mild to severe. So an upper endoscopy is a very useful test for some people with acid reflux. Clearly, everybody cannot get an acid upper endoscopy because 10 to 20% of the population has reflux. We have to be selective in whom we recommend an upper endoscopy. There are some new tests for the diagnosis of acid reflux. The first test is called Bravo. This is a very good test. We do an upper endoscopy, and then we attach a small probe to your lower esophagus, and then you go home with a monitor, and it measures the amount of acid over 2 days. This is considered the gold standard test for acid reflux. It's typically done before surgery, or if the symptoms are atypical and you're not sure if somebody has GERD or not. The other test, called manometry, is done when you're awake, but it's a very short test. They pass a probe into your esophagus, and they measure how the esophagus contracts. This again is typically done before surgery, or somebody presents with severe chest pain or trouble swallowing. And they're very useful techniques. Again, we have to be very selective in who gets this test. So you go to the doctor, he listens to you, he diagnoses you with GERD, he may or may not do an upper endoscopy and some advanced testing. How do we treat acid reflux? The three main lifestyle modifications that help acid reflux are weight loss, elevate the head end of the bed using blocks of wood or a wedge pillow, and not eating for 2 to 3 hours after meals. In large studies, these are actually the only three lifestyle modifications that have been actually shown to help people with acid reflux. But there are other smaller things you can do. For example, stay away from acidic and caffeinated products, avoid tight garments, avoid alcohol, smoking, and using chewing gum to increase salivation. Now, patients sometimes obsess about these little things like not having mint or completely staying away from tomatoes. The truth is, as long as they moderate their dietary intake, we don't need to go crazy about it and never have pizza or never have red wine. As long as they do the first three things, the dietary modifications can be moderated rather than complete abstention. After we initiate the lifestyle changes, typically we prescribe medications. Amongst gastroenterologists, there are two main schools of thought. One is called the bottom-up school of treatment, and the other is the top-down school of treatment. The first thought believes that you should start with a milder medication and then progress up to stronger. And the second group believes that you start with the highest, get the symptoms under control, and then go down. The truth is, most of us follow like a hybrid approach. I'm more of a bottom-up approach, if you want to know. Okay, so the most commonly used medications are antacids. These are Tums, Mylanta, Pepcid C. These are all available over the counter. They're inexpensive. They start working within 5 days, and they can last up to an hour. They are used on demand for mild GERD, and they can be used along with other medications. The second group of medications are H2 receptor antagonists. Everybody's seen them on their shelves or in the pharmacy. These go by names like Tagamet, Zantac, Pepcid, and Axid. These are over the counter, no longer prescription. They have an excellent safety profile. They're inexpensive. They are effective for a little more severe GERD. They're not effective for patients with NERD or with erosive esophagitis, and some patients who use them regularly can become tolerant. The third group of medications are called PPIs. I'm sure many of you are familiar with this. In many countries, PPIs are the most prescribed medications in the world. There are 6 major, one of them, everybody's heard about Prilosec. They are the most potent acid suppressants. They're available with and without a prescription. They have a good long-term safety profile, and they're best used before breakfast. They have very good healing rates, up to 90% for esophagitis, and they can be used at higher doses twice a day for people who don't respond to once a day. Occasionally, they interact with other drugs. Now, many of my patients have seen ads or you've read about the long-term concerns of PPIs. Some initial data suggests that people who take acid suppressive drugs like PPIs are at higher risk of some infections. They have a low magnesium, they can have low B12, higher risk of bone fractures, kidney damage, dementia, and pneumonia. I just came back from the biggest GI conference in the United States, and there was a whole session on this. The consensus among the experts is that while these side effects can happen, they're very rare. So, for example, bone fractures. The number we got was 1 in 900 patients. That is, 900 patients have to take a PPI regularly to get one patient with a bone fracture. So even though these are concerns, they are pretty rare. So don't stop taking your PPIs for this reason. But it is wise to take the least amount of PPI that you can get away with. I try to have my patients take it 3 days a week or as needed rather than on a regular basis. There are other medications that you can use for GERD. These are typically used for patients who don't respond to first-line medications. They include sucralfate, sodium alginate, baclofen, and Reglan. What about surgery for GERD? As I mentioned before, short of surgery, we still don't have a good mechanism to tighten the valve between the esophagus and stomach. Surgery can fix reflux. It is typically reserved for people who fail medical treatment, who don't like to take medications, or who are intolerant, or who have complications. And basically, there are 3 surgeries. The first surgery is called Nissen fundoplication. This is done through a keyhole, laparoscopic, where a surgeon goes in and wraps the stomach around the esophagus. It's the oldest reflux surgery. The second surgery is where they place a series of magnetic bands around the lower esophagus. This is called LINX. LINX is slowly becoming more and more popular. And third is bariatric surgery. Well, patients ask me, how is this a reflux surgery? Well, we know that obesity is the #1 risk factor for reflux disease. And patients who have acid reflux and whose basal metabolic index, body mass index, is above 35 should be offered bariatric surgery. And bariatric surgery is very effective for acid reflux and for weight loss. Unfortunately, the endoscopic techniques, some of which I trained in, have not lived up to their potential benefit. In my opinion, endoscopic treatment should be only done as part of a clinical trial currently. In other words, they're not ready for prime time. Reflux is a very common problem, and there are several new drugs that are being studied in clinical trials for chronic acid reflux. And some of them will be coming to market in the next couple of years. You can see it's a very long laundry list, and if you go to clinicaltrials.gov, you may be able to participate in some of these trials. Well, as I told you at the start of the talk, I have a deep interest in clinical research. And currently, we have a treatment that is available as part of a clinical trial. This is a new drug called vonoprazan. It's available in Japan, where it's the #1 prescribed drug. It seems to be much more stronger than currently available acid reflux. And we have an ongoing clinical trial where you get an upper endoscopy for free. And if you have NERD, which is non-erosive reflux disease, which, if you remember, means that there is no damage, then you will qualify for the clinical trial. Participants in the trial get a free medical evaluation, free endoscopy, lab work, access to cutting-edge medication, and a small stipend. If any of you are interested in participating in the clinical trial, please visit us at ebgcr.com. You can also find us at clinicaltrials.gov, and that is the phone number for Encore Board and Brewer Clinical Research. So that, in a nutshell, is a lot of information about acid reflux. It's very common. Medications are available, surgery is available, and we have these new drugs in clinical trials. So I'm going to stop here and give you a chance to ask any questions. How do I do that?
Just tell them to write in the chat.
Oh, yeah. So I'm being told that the best way to ask questions is to go to the chat part of the app and write your questions. And then I'll do my best to answer it. And we'll just wait for a couple of minutes while people have any questions. And feel free. I've tried to explain it to you the way I would explain it to my patients in my clinic. And almost all the Board and Gruber doctors treat gastroesophageal reflux disease. It's kind of a bread and butter practice. All right, we have a question from Catherine. So Catherine is asking, does GERD cause snoring? And the answer to that is no. Snoring is typically caused by what we call obstructive sleep apnea. That is, if you gain a lot of weight and if you have a narrow airway and you lie down, the diaphragm pushes the chest and everything up, and your upper airway then closes, and that, I believe, is the most common cause of snoring. Now, being overweight and having sleep apnea is a risk factor for obstruction and snoring and acid reflux. So patients can have both acid reflux and sleep apnea, but the acid reflux does not cause sleep apnea or snoring. Okay, I have a question from Mary. Does excessive stress contribute to GERD? I believe it does. So when I'm having a very stressful day, I get heartburn. And, I have a little antacid right by my desk. So how does stress cause acid reflux? First is short term. Stress increases the amount of acid production in your stomach, almost doubles it. And then it diminishes the body's natural antacid, which is saliva. This combination of high acid, low saliva causes acid reflux. The second way stress causes acid reflux is stressful people take a lot of ibuprofen, alcohol, they may gain weight, they may not eat healthy, and that leads to weight gain and acid reflux. So stress is a contributing factor for both short-term and long-term reflux. Okay, we have a question from Julia. How does a hiatal hernia affect GERD? Now, this is a very interesting topic because most people with hiatal hernia don't have acid reflux. What we know now is that if you have a hiatal hernia and you have acid reflux, the reflux is more severe. If you have obesity, you're more likely to get a hiatal hernia and a reflux. So in some patients, especially if you're overweight, a hiatal hernia damages the valve and causes acid reflux. If the hiatal hernia is very large, sometimes you need surgery to fix the hernia. So to answer the question, hiatal hernia can definitely cause acid reflux. It is a contributor to severe reflux, and large hernias may require surgery. Okay. We have a question from Maureen. Maureen is saying, is there a limit to how long you can be on an ATC RX? No. You can take the over-the-counter medications for as long as you have acid reflux. Now, on some of the stronger medications like Prilosec, it says that you can take it for more than 2 months. Well, the reason for that is, as I told you, acid reflux and heartburn can sometimes lead to damage to the esophagus and cancer. So if you've had acid reflux for 2 months and you're taking these strong medications like Prilosec every day, then you should see a doctor. But there is no time limit as to how long you can take these medications over the counter. All right. Julia has another question. My heart palpitations follow bloating and GERD. What is the connection? Okay, so palpitations are typically not caused by acid reflux or bloating. But in some patients, especially if their stomach doesn't empty very well, then it gets distended and applies pressure on the diaphragm and thus can irritate the nerve. So heartburn does not cause palpitations, but sometimes because the esophagus is located right next to the heart and to the major nerves called the vagus nerves, it can cause occasionally palpitations. Denise has a question. I have taken PPIs for years. My blood work is showing kidney problems. I'm a 73-year-old woman. I thought having procedures like TIF, and I've had 2 endoscopies over the years. I do have a small hiatal hernia. Okay, so as I mentioned to you, the incidence of kidney damage in patients who take PPIs is very low. But having said that, it's not zero. If you've been taking PPIs for a long time and you want to try and get off them for many reasons, then my opinion is that the endoscopic, and this is my personal opinion, some of my partners will disagree on this, but it's my personal opinion that the endoscopic procedures for reflux haven't met the safety bar. If you do want to think about having surgery, then my current favorite procedure is the LINX procedure, and the second one is Nissen fundoplication. If your hiatal hernia is less than 2 centimeters, you can have the LINX. If it's more than 2 centimeters, some surgeons would say you're better off having a Nissen fundoplication. So to answer your questions, PPIs are not commonly associated with kidney damage, but if you want to come off of it, you have to think about either LINX or Nissen fundoplication. If you're very overweight, then bariatric surgery, as I had mentioned. I have a question from SMT510. Aren't these medications tough on the kidneys? So it is true that a very small number of people get interstitial nephritis from PPIs, but the actual number is very low. I believe the number is 1 in 700 something patients. So remember, PPIs are the most commonly prescribed drugs in the world. And at any one time, say 10, 20% of the population is on the medication. But there are millions of patients who take it. And the way I would put it is, if you had normal kidney functions before you took the PPI, you started the PPI, and within 2 months there was a worsening, then yes. But that is pretty rare. I have another question. So you would not suggest TIF to get off the PPIs? Again, as I told you, there is a little bit of controversy amongst my partners and among gastroenterologists about TIF, which is an endoscopic way of strengthening the lower esophagus. I am personally not a big fan of TIF. I actually trained in it also, but I believe that the long-term data suggests that either a Nissen fundoplication or more better placing the LINX, magnetic LINX, is probably a better way to come off the PPIs. Now, again, gastroenterologists hate to talk about surgeons doing a better job, but I think the data is reasonably clear that for reflux surgery, the surgeons are already there. Now, there are several other new techniques that we're looking at in clinical trials. In 6 months or a year from now, maybe there will be a safe endoscopic technique. But as of now, I'm not saying you should not have it done, but you should be a little cautious about it because the data is much stronger for surgery than for endoscopic procedures like TIF. All right, I think that's I think that's all the questions we've had so far. Anybody else have any questions? All right. So I thank all of you for participating. And remember, all gastroenterologists treat reflux. This is a big part of our continuing education. There's a lot of new data keeps coming in. And please feel free to see a gastroenterologist of your choice at Borland Gruber Clinic, Mayo Clinic, UF, and write down a list of questions, and they will guide you in the right direction. So thank you, everybody, for coming, and stay safe.